So here we have the 5 centimeter rectal lesion. The first part of the dissection involves submucosal injection, followed by a mucosal incision to isolate the lesion proximally. There we see just touching a vessel. It's not a problem with the Speedboat notch. We can apply microwave coagulation immediately and then continue the dissection. Here, rather than using a tunneling technique, I decided to do a conventional ESD and just cut around the lesion and then use the weight of the lesion hanging down with gravity to create a nice flap, which provided a fairly rapid dissection. What I particularly like about the Speedboat notch is the fact that we can use the notch to hook around the back of a vessel, apply microwave coagulation and then cut. Here's a bigger vessel. You can see the Speedboat's advanced slightly and then pull back to engage it in the notch, apply microwave coagulation. Bursts of anything up to 10 seconds, sometimes repeated, and then followed by the bipolar cutting. Little bit of additional bleeding there, so it needed another burst of the microwave. But at no point during this dissection were the coagulation forceps required. A little bit further with the microwave, just some more to control the bleeding there, and then it can be cut through. The dissection tends to be slow at the point where there's a vessel, and then much more rapid once you get into the submucosal plane. You can use the notch to catch the submucosal tissue and dissect fairly rapidly. Here's a vessel again, so microwave coagulation. Note how the tip of the Speedboat is orientated so that the hull is adjacent to the muscle when we're cutting here or using microwave coagulation to minimize any thermal injury to the muscle layer. Nice submucosal plane here, again coming onto a vessel, so just dissect up to that, then pause, hook up and away from the vessel, apply microwave coagulation. You can see the bubbling that shows, and the whitening of the tissue shows that the vessel has been adequately coagulated. And then we can just keep that orientation and continue the dissection fairly rapidly. More submucosal dissection here. You can see even without traction there's nice tension on the tissue just from the sheer weight of the lesion. Further on in the dissection, we've now established a good flap. I quite like to maintain a straight cap with this type of dissection because it gives you a better field of view rather than confining your field of view the way that the ST hood does if you're in a tunnel. So here we're maintaining good visualization all the time, cleaning the lens, the vessel is coagulated and then cut, and the dissection proceeds with the cap separating the lesion from the underlying muscle. More microwave coagulation. A certain amount of smoke is generated, but that can be aspirated. And here we are towards the end. You can see the specimen is just hanging away from the field of view, which is convenient. The Speedboat is orientated with the hull towards the muscle, and particularly with the notch to catch the final rim of tissue and complete the cut is very easy. And there we are, a fully resected lesion. Notice there isn't much thermal injury to the muscle layer, if at all, with intact submucosa.